السلام عليكم everyone. This is Dr. حنان عليان. بتمنى تكونوا كلكم بخير صحة وسلامة. This is part 3 of the craniofacial growth. So in this lecture we will continue to talk about the pattern of growth postnatally, particularly of the structures that we didn't speak about last time. Last time we spoke about the cranial vault. This time we will discuss the growth of the cranial base, of the nasomaxillary complex, and the mandible. We will talk about the clinical implications of this growth. We will talk about the growth of soft tissues, growth rotations, and some theories and genetic and environmental control of this growth, as well as the importance of growth prediction in orthodontics. So what you need to understand about facial growth is that all studies indicate that growth proceeds in a downward and forward direction of the face and its structures away from the cranial base. Okay? Every structure in the craniofacial complex has its own rate, timing of growth, and is under the influence of different genetic and environmental factors. This is just a picture to show you how the maxilla, mandible, and the maxillary alveolar process and the mandibular alveolar process, when they grow in harmony, they give a harmonic face. However, if one of them or two or three, they don't grow in harmony with each other, we will have different facial forms, different malocclusions, okay? And some of them are not in harmony at all. So remembering the cephalocaudal gradient that we spoke about and Scammell's curve of growth, remember, as we said, that during the first few years of life, up until the age of around 7, there is a very high rate of growth of the neural tissues, mainly the brain. So we can expect from the gradient that the brain and the structures closer to it have the maximum growth around this time of period, like the clavarium and the orbits. And then structures that are further away, they will grow later on, like the maxilla and the mandible. So when we compare the skulls of an adult and a child, we can see that the face in the child makes a very small percentage of the skull, but then it makes a bigger percentage as the child grows and becomes an adult. We also remember that pubertal growth spurt and reaching puberty is different for different people regarding the onset or timing. However, on average, it's around the age of 10 to 12 in girls and 12 to 15 in boys. So this is Scammell's curve again, وضفنا عليه الماكسيلا والمانديبل, and you can see that the maxilla curve resembles the neural curve in shape. Okay, so it is high in the first few years of life and then it slows down until it reaches the maximum size, خلينا نحكي. بينما the mandibular one, it looks more like the somatic curve or the general curve that is S-shaped. It has a high rate and then it plateaus a little bit and then it accelerates again around the pubertal growth spurt. So we can expect more growth of the mandible around the pubertal growth spurt. At the end, when they reach this level, we will say that facial growth doesn't really stop, it just reduces to adult levels with subtle long-term changes throughout life. And this is something to note, and it's very important to us as dentists and orthodontists. Let's begin with the cranial base. The cranial base actually develops by endochondral ossification, and its growth is of course influenced by growth of the brain. If you remember the embryo, there is a continuous plate of cartilage extending from the nasal capsule anteriorly all the way posteriorly to the foramen magnum. هذا الcartilage plate is thin and it's called the chondrocranium. During the 4th month in utero, يعني تقريبا شهرين بعد ما الcranial vault تكون already بلشت. Remember the cephalocaudal gradient. Cranial vault بلشت أول بعدين cranial base. Okay, during the 4th month راح يبلش يصير في عنا ingrowth of blood vessels، وكل منطقة بفوت فيها ingrowth of blood vessels راح تبلش يصير فيها ossification. So راح يصير عنا مناطق ossification منتشرة جوا هاي الكوندوكرانيوم، okay, and then حتبلش هاي المناطق to fuse to form what will the future be the bones of the cranial base. The bones of the cranial base اللي هم ال basioccipital, the sphenoid and the ethmoidal bones. Okay, eventually the chondrocranium will be represented by only small bands of cartilage interposed between large sections of bone. So here this is a different view from the top. Okay, هذا كان بالأول cartilage بس دخلوا vascular elements صار يصير فيه ossification areas فصار عندنا زي 3 different bones interposed بيناتهم bands of cartilage. Okay, البونز هم the ethmoid, the sphenoid and the occipital bone, right? And this is the side view. هلا الجروث اللي راح يكمل ب these sites of the cartilage, okay, it is the major component for the anterior posterior growth of the cranial base. Okay, these cartilaginous areas are called synchondroses و they are named according to their position. يعني الأولى اللي between the ethmoid and the sphenoid is called the sphenoethmoidal synchondroses. Okay, uh, the second one is between the two sections of the sphenoid bone and it's called the intersphenoid, and the third one is between the sphenoid bone and the occipital and it's called the sphenooccipital synchondrosis. Histologically, they look like a two-sided epiphyseal plate. يعني there are cartilage cells proliferating in both directions from these synchondroses, and as they proliferate, they get ossified and they add to the length of this cranial base. So remember the epiphyseal plate where the cartilage is growing in both directions, very similar. You can think of the synchondroses and they are elongating the cranial base in both directions. Now what you need to know is that the most posterior synchondroses of them all اللي هي السفينوoccipital هي أكتر واحدة بتكمل نمو وبتتأخر بالنمو وأكتر واحدة بتعطي نمو للcranial base in length. Okay, so it continues to grow up until the age of around 15 in females and 17 in males and fuses around the age of 20 years يعني well into adulthood. بينما the most anterior two synchondroses they grow rapidly in the first few years up until the age of 7 and then after the age of 7 there is no growth at all in that region. هذا الحكي ليه مهم عشان نعتبر الانتيريور cranial base المنطقة الانتيريور هي منطقة بعد عمر 7 سنين منطقة stable. وبكرة لما تاخدوا محاضرة اللاترال cephalometry اللي هي الإكس راي بناخدها للهيد from the side نعتبر دائما إنه هاي المنطقة stable and it helps us to superimpose X-rays on each other to compare the growth of the face مثلا for the same patient. So how does this affect the clinical relations that we see in real life? Remember, this is the cranial base and the epiphyseal plate اللي هو synchondrosis هذا. It grows in both directions and lengthens this cranial base. The cranial base is attached to the temporal bone that has the clinoid fossa or where the TMJ articulates. So as the cranial base elongates, it could carry the glenoid fossa a little back to the back. And if this happens, it will carry the mandible with it to the back, and this we can see a class 2 relationship. خلينا نطلع على السلايد اللي بعدها عشان نفهم أحسن. So this is a comparison of two patients, both of which have mandibular growth, okay, by around 7 millimeters. However, في واحد لما راقبوه لقوا إنه المانديبل grew وقدم لقدام والتاني the mandible grew صار أكبر however ما قدم لقدام, and this was because the cranial base grew in a way that it carried the temporal bone and the glenoid fossa to the back, so it masked the growth of the mandible. Okay, so بهمنا the cranial base not only in the length but also in the angle or the shape. Okay, you can see that there are different angles of the cranial base بنسميها هاي saddle angle, هاي anterior to the posterior. Okay, the more acute it is or small, okay, it will take the temporal bone or the glenoid fossa most anterior, thus the mandible more anterior, and so there will be more tendency towards a class 3. The more obtuse the angle or larger, it will carry the temporomandibular joint to the back, and the more there's a tendency for a class 2. Now let's discuss the maxilla or the entire nasomaxillary complex. So the maxillary complex or the middle third of the face has many structures and bones. It has the maxilla, the palatal bone, the zygomatic, the vomer, and the nasal bones. Okay, these separate bones, they join each other and they join the anterior cranial base at sutures. So the growth of the complex is an important factor in the position of the upper teeth طبعا in relation to the entire face. So coming now to the maxilla. The maxilla زي ما حكينا قبل it forms by intermembranous ossification. يعني ما كان في إلها cartilage middle من الأول that gets ossified. No, it's purely intermembranous and it starts in the maxillary processes. Remember this embryonic stage. في عنا maxillary process وبلش يصير فيها mesenchymal condensation lateral to the nasal capsule. Okay? So as the maxilla and the nasomaxillary structure forms, it kind of needs to grow out from underneath the cranium. So this means that the maxilla needs to move out a considerable distance. And how does this happen? The growth of the maxilla depends on two things. Okay, أول إشي في عنا sutures that are positioned superiorly and posteriorly that connects the maxilla to the cranial base. At these sutures, bone will be formed. Bone apposition on the top will push it down. Bone apposition on the back will push it forward. So these sutures together will help push the maxilla downward and forward. And this is called growth at the sutures that causes primary displacement of the maxilla. There is also secondary displacement because the maxilla, as it is attached to the cranial base and the cranial base is also growing, it will also push it downward and forward, and this is called secondary displacement. So حنشوف إنه المجزلة بأول 7 سنين من العمر it gets pushed to the front, and a large portion of that is due to the growth of the cranial base. But after that, all the growing of the maxilla is due to primary displacement or bony growth at the sutures. Now, as the maxilla grows forward, the downward and forward movement, there is a space that would open on the back. وهون رح يصير برضو عنا bony infill. As bone fills on the posterior side of the maxilla رح يصير في عنا more space for the permanent molars to erupt. هلا في عنا بالماكسيلا كمان إشي مهم غير السوتشرال growth اللي هو ال surface remodeling, and it's quite dramatic in the maxilla. Let's look at the next slide. So as we said, surface remodeling is quite extensive in the maxilla, and the interesting thing about it is that actually surface remodeling occurs largely by removal of bone from the frontal surface. So تذكر كيف احنا حكينا the maxilla goes forward and downward. Okay, however, there is also extensive remodeling that removes bone from the front. This doesn't negate the forward and downward movement. يعني ال removal of bone ما بيلغي ال forward and downward movement لأنه much less. However, it dramatically affects the shape. So it kind of هذا المثال إذا بتطلعوا عليه إنه عرباية عم تنجر هي كلها عم تتوجه بهذا الاتجاه. It will continue to move in that way, but the wall is being changed in shape. عم بيشيله من قدام وعم بحطه عليه من ورا. Okay. في كمان اتجاهين بالsurface remodeling بدنا نحكي عنهم. The downward growth of the palate, actually it goes additively to the growth of the maxilla. As it grows forward and downward, there is also addition of bone on the palatal surface from the palatal side and removal from the nasal side. So it also helps push the palate to move further down. Okay, but when we talk about laterally, we also say that for the mid-palatal suture, there is a tension on the two palatal halves to go laterally, and then there will be bony infill in the mid-palatal suture. So to sum up, the nasomaxillary complex, the maxilla forms by intermembranous ossification. There are superior and posterior sutures that connect it to the cranial base, and these are ideal for sutural growth. Bony opposition that pushes it forward and downward. Primary displacement. cranial base, as it elongates, it also pushes it downward and forward. This is called secondary displacement. We also want to say that there is surface remodeling that is extensive with removal from the frontal side. And when we talk about the palatal side or the palate, there is addition on the palatal side and removal from the nasal side. Okay? And from the midline, when we look at the transverse direction, there is also addition of bone on the mid-palatal suture. Okay, so what are the clinical implications of what we just studied? خلينا نطلع على growth of the maxilla. حكينا بأول 7 سنين it is affected by the cranial base growth. It pushes it forward. So إذا صار عندي مشكلة بالcranial base growth, like in the case of achondroplasia, لما يكون في عنا missing cartilaginous tissue, the maxilla will not be pushed forward in these first few years of life. So there will be always some sort of mid-face deficiency, like in this case of achondroplasia. You can appreciate قديش الميد-face هون والماكسيلا راجعة لورا. طيب شو كمان بهمني إنه إحنا we can do orthodontic intervention to advance the maxilla. أوكي، هذا الجهاز رح تاخدوه لقدام اسمه reversible headgear. إذا بتطلعوا الطفل لابسه وحاطط مطاط عشان يشد الماكسيلا لقدام. And this is very successful before the age of 10 years old, before the sutures اللي posterior and superior to the maxilla start to fuse. Before that age, these sutures are still amenable to stimulation and we can pull the maxilla forward. Another example, if we want to do expansion of the maxilla. Before the age of 15-16, the mid-palatal suture is still not fused. So when we put an expander like this and open the jack screw, the two halves will get separated. After that, the suture in the middle will somewhat fuse, and then the maxilla cannot be separated. أنا بدي إياكم بس تفهموا هاي الكلينيكال implications أكتر من إنكم تحفظوها، لأنه رح ترجعوا تاخدوها بمحاضرات تانية لقدام. شو كمان الكراوزن سيندروم؟ تتذكروا لما حكينا بالمحاضرة الماضية على الإشي اللي هو اسمه craniosynostosis اللي هو fusion of the sutures، صح؟ Fusion of the sutures can also happen in the superior and posterior sutures of the maxilla. Okay, and then we can see another mid-face deficiency. Okay, and it's very most common one of the craniosynostosis is called the Crowden syndrome. And you can see this premature fusion, okay, extends, and you can see that the orbits look enlarged because mostly the mid-face is very deficient. Let's come to the mandible now. The mandible actually forms by both intramembranous ossification and endochondral ossification, but for the most part, intramembranous ossification is responsible for most of the mandible's development. How does it start? It starts by mesenchymal condensation, just lateral to Meckel's cartilage, okay, and follows the pattern. However, Meckel's cartilage does not at all ossify or contribute to the bone of the mandible, and it later on disintegrates. Now, this is the intermembranous ossification that started here, and then there is also the condylar cartilage that starts a process of endochondral ossification here at a separate area. The bone starts forming in this direction and forming from this direction until they later on fuse. The cartilage of the condyle is not like that of the synchrondosis. However, there is still hyperplasia and endochondral replacement occurring here. Now, the principal sites of the growth of the mandible are the posterior surface of the ramus and the condylar and coronoid process. There is actually little or none growth existent at the chin level or the anterior region. Okay, as the soft tissues in which the mandible is embedded pulls it downward and forward, bone fills up by the endochondral ossification at the condyle, increasing the ramal height and maintaining contact at the TMJ. Now, what is interesting is that how does the body of the mandible grow from this small size to this adult full size? Okay, how does this become this long? There is no interstitial growth in bone حكينا صح؟ ما بتقدر هاي الشقفة تطول ولا في عندي cartilage model here. So how does this section gets longer? Easily by removal of bone from this side, the anterior side of the ramus, and a position on the back side of the ramus. So as bone is removed from this side and added from this side, this length of the mandible body becomes longer. Okay, so what was the posterior side at some point يعني هاي رح يكون في bony removal من قدامها وبوني opposition وراها رح تصير هون في مرحلة ما the anterior side. كانت قبل the posterior side, now it became the anterior side. This allows the body to grow and allows more room to accommodate the erupting teeth and the primary molars and then later the permanent molars. However, more often than not, this growth ceases well before enough space has been created for the eruption of the third permanent molars, which in result get impacted. There is also secondary displacement of the mandible as the cranial base grows, so it will push the temporal bone down. Okay, and sometimes, but very rare, it will take the temporal bone a little bit to the back, as we said, and will take the mandible back. So to sum the mandible up, في عنا intramembranous ossification that began lateral to Meckel's cartilage. في عنا endochondral ossification around the condylar cartilage that occurs here, and then these two parts join. The endochondral ossification that occurs in the condylar process is what helps the ramus grow in height. And we have the bony opposition by the periosteum on the posterior surface of the ramus, and bone removal from the anterior side helps the mandible body grow in length and makes room for the teeth to erupt into it. Okay, there's also surface remodeling that maintains the shape of the mandible just like the maxilla, and it allows the transverse ingrowth by bony opposition on the outside and removal from the inside. Secondary displacement by growth of the cranial base rarely affects the mandible. Usually, the mandibular growth follows a steady rate of around 1 to 2 mm increase in the ramal height per year and 2 to 3 mm increase in the body length per year. هذا الريت لما تيجي للpubertal spurt it will double. زي ما حكينا the mandibular growth follows the somatic, so it's going at نوعا ما a steady rate, but around the pubertal growth spurt it will accelerate. This rate will double. And again and again and again the cephalocaudal gradient, the maxilla will stop growing or slow down to the adult levels of growing or adult rate of growing around the age of 12 to 15 years. The mandible طبعا from the cephalocaudal gradient it will be later than that. So the mandible will continue to grow up until the age of around 17 in girls and 19 in boys. Now we want to talk about something called growth rotations. So مش حكينا الفيس grows forward and downward. هو مش straight line. Sometimes it rotates in a clockwise or an anti-clockwise direction. Okay. مين اللي اكتشف هذا الإشي اللي كتير مهم؟ عالم اسمه بيورك. بيورك كان يحط خلينا نحكي bony implants inside the bone and then follows the path of growth and اكتشف إنه دائما في element of rotation. طيب كيف بتصير هاي element of rotation؟ لأنه في عنا إشي اسمه posterior facial height وفي عنا إشي اسمه anterior facial height. لما ما يكونوا التنين عم بيصير فيهم growth قد بعض، let's say anterior facial height عم بينمو أكتر من posterior facial height, then the growth will be backward. The opposite is true. If the posterior facial height is growing more than the anterior facial height, then the growth will be forward. Okay? So في أشياء بتحدد ال posterior facial height اللي هي مثلا direction of growth of the condyles, the vertical growth of the synchrondosis, the spheno-occipital one, and the influence of the attached muscles on the ramus of the mandible. What affects the anterior growth؟ قديش عم بيصير في عنا eruption of teeth، قديش في عنا ال soft tissues of the anterior neck are affecting the growth of the bones here. So according to Bjork's studies, الماكسيلا بصير فيها rotation بس it's mostly negligible and it is خلينا نحكي concealed or masked by the extensive surface remodeling اللي بصير. فأنا لما أطلع على هاي الصورة وأشوف superimposition of this patient as he grows بال 3 lines بشوف إنه نوعا ما الماكسيلا مش كتير صار فيها rotation، بينما إذا بتطلع على الماندبل بشوف very masked or obvious rotation, and this is actually true always. Maxilla has negligible rotations بينما the mandible الروتيشن فيه أوضح. هلا most of the people are forward rotators of the mandible, and this is the normal to expect some sort of a very mild forward rotation of the mandible لقدام of 3 to 4 degrees. Okay, 80% of people are forward rotators. There is 20% who are backward rotators. طبعا هاي ال growth rotations of the mandible طبعا رح يكون لها effect على ال malocclusion وعلى ال facial harmony and a lot of things. Okay, زي ما حكينا normal is to have a very mild forward growth rotation which is 3 to 4 degrees. Okay, however, if we have a marked forward growth rotation, we can expect that forward growth rotation, like this case, okay, it will decrease the anterior facial height and it will give a tendency towards a deep bite anteriorly. It will also carry the mandible forward with it. So إذا كنا عم نعمل correction ل class 2 treatment والpatient is a forward growth rotation, we can expect that the treatment will gonna be stable because the mandible will continue to grow up and forward, and so the patient will become less and less class 2. بينما if the patient is a backward growth rotator, like this case, the backward rotation of the mandible will increase the lower facial height, will also give me a tendency towards an open bite. The mandible is growing back and away from the maxilla and downward. Also because it's growing back and downward will give me more tendency towards a class 2. So if I say I corrected a patient's class 2 malocclusion بعديها هو كمل الجروث تبعه رح يرجع I can expect the overjet to increase again because the mandible will continue to grow backward. طب let's talk a little bit about the soft tissues. The soft tissue drape اللي بنسميه زي الستارة فوق ال hard tissues. Okay, sometimes they mask an underlying skeletal relationship, they cover it, and sometimes they actually accentuate it, يعني بيزيدوا حدتها. Okay, هلا important concept to know is that بالآخر soft tissues مش شرط they parallel the growth of the hard tissues underneath them. So إذا بدنا نحكي على lips are maximum thickness around pubertal growth spurt, and after that they start reducing in size. So you can expect the lips to become thinner and thinner as the patient age. Now if we want to talk about lip height أو طول الشفة بدنا نعرف إنه هو بيكون shortest during childhood and during the mixed dentition age. يعني بهذا الوقت بيكون الشفة قصيرة، بيكون طبيعي إنه نشوف gummy smile لما البيشنت يضحك. This is very normal gum show in young patients. And also the lip separation at rest، يعني lips could be at the age of mixed dentition somewhat incompetent، يعني at rest ما بيوصلوا لبعض. And then they will continue to grow more in height, more and more, and so we will see less and less of the gingiva. Even in older patients, we will see less of the upper teeth and more of the bottom teeth because of continued decrease in height and also because of the sagging of the soft tissues as the patient ages. So it is normal to see a gummy smile in young patients, not so much in older ones. If I see a gummy smile in a young patient, that does not mean that I need to intervene to correct it. It will self-correct as the patient grows older. A quick talk about the nose. The nasal bone continues growth by the age of 10, and after that all of the changes are because of the nasal cartilage. It grows in all sorts of dimension, remodeling and lateral, and we can see considerable changes, especially in boys around the pubertal growth spurt. A short talk about the theories of facial growth. What actually affects the growth of the face? Okay, there are three major theories. واحدة بتقول that bone is like any other tissue. It is the primary determinant of its own growth. And then there is the cartilage theory that says no, actually cartilage is the primary determinant of skeletal growth and bone just responds secondarily and passively to it. And then there is the third theory that says actually soft tissue matrix in which the skeletal elements are embedded is the primary determinant of growth, and both bone and cartilage just respond to that and they are secondary followers. So ايش الفرق بين هدول الثري theories؟ إنه كل واحدة it postulates a different location for the expression of genetic control. هلا in contemporary thought in orthodontics there is truth to be found somewhere between the second and the third theories, and the first one is largely abandoned. عشان نكمل نحكي بهدول الثيوريز بدنا نحكي الفرق بين شغلتين growth site and growth center. So the growth site is merely a site or a location where growth occurs. بينما a center is a location where it independently and genetically controls the growth. Okay, so all centers of growth are sites, however, not all sites are centers. So if we want to talk about the first theory that says bone is the primary determinant of its own growth by its sutural growth, this theory was not supported by the experimental evidence because transplantation of the sutures of the bone proved that these sutures have no innate capacity for growth. Okay. However, if the suture is compressed or stretched, then the growth will be affected. So this means high sutures are not growth centers, they are merely growth sites. So this theory, the second one, زي ما حكينا, it is somewhat to a certain extent supported by some evidence. Okay, it says that cartilage has some innate capacity for growth, and when it was transplanted, actually some cartilage did show that capacity for independent growth, زي الابiphyseal plates, and to some extent its synchrondosis and the nasal septum. However, the condylar cartilage shows much less capacity for independent growth. So now we speak of the condyle as just a growth site, بينما synchrondosis and nasal septum can act as true growth centers. The functional matrix theory is the most acceptable one, the closest one to the truth. It was put forth by a scientist called Moss. Okay, and it says that basically the development of the soft tissues is what initiates, directs, and controls the growth of the bones embedded in them. Okay, an example is that growth of the face occurs in response to functional needs mediated by the soft tissues. The growth of the cranial vault is a direct response to growth of the brain. An example of that is that if a patient has microcephaly, a small brain, they will have a small cranial vault. If they have a hydrocephaly, they will also have a cranial vault that resembles the shape of the brain of the hydrocephaly. Okay, if we talk about the maxilla and the mandible, the largest determinant of their growth is the nasal and oral cavities. Okay, the mandible in particular demonstrates a strong interaction between or with the muscular activity. Okay, especially as these muscular changes can affect the shape and size of the mandibular growth. So, for the sake of carrying the conversation here, we can look at the mandible as a body that has several functional processes. So it has the alveolar process, whose function is mastication, and affected. The eruption and the dental eruption in this alveolar process is affected by the mastication process, right? It has the condylar process, whose function is articulation, the TMJ. It has the coronoid process that has a lot of muscles attachments, so the shape of the angle here and the size here could be affected by the muscles attached to it. The shape of the mandible could be driven forward largely by growth of the tongue here in the middle. So what are the clinical implications of this functional matrix theory? That actually changing the functional environment might influence the muscle activity and thereby modify the bone growth. Okay, so this is very important if we have a patient with a certain skeletal malocclusion we can do something called growth modification. You will take lectures about that later on, which means that I can modify the soft tissue environment around these bones, and so I can modify these bones directly and affect the relationship to each other. So what does this mean? Is that as the maxilla has sutures, and we know that these sutures are growth sites and not centers, then these growth sites respond well to stimuli. Whether I want to stimulate the forward growth and more bony opposition at these sutures, like in the case of class 3, or I want to actually try to restrict or inhibit growth at these sutures and try to hold the maxilla back while allowing the mandible to grow forward in class 2 patients. I can also try to stimulate mandibular growth, okay, by changing the soft tissues around it and allow more growth by the endochondral and intermembranous ossification by trying to pull the mandible forward. However, there are no sutures, so I cannot try to restrict the growth of the mandible, and this is shown by lots of evidence, and we will talk about this later on in growth modification lectures. طبعا كمان لما احنا نفهم ال growth timing of different structures of the craniofacial complex, it tells me when is the most optimum timing to intervene to affect the skeletal relationship. صح؟ زي ما حكينا الماكسيلا بدنا نفوت at an earlier age بينما المانديبل بدنا نفوت at somewhat a later age. However, we still need to intervene while the patient is growing. After that, growth is almost stopped or slows to very, very slow rates, which are the adult rates, and we can't do much about it. And if we want to change the skeletal relationship for an adult, then the only choice for us is usually surgery. So as we said, there's the genetic factors. زي ما حكينا في عنا growth sites, في عنا growth centers. The growth centers have their own innate capacity for growth, and the growth sites respond to the growth centers or respond to the functional matrix around them. And this is all according to certain genetics and genetic expression. However, if it was purely genetic, then as we said ما نقدر نعمل إحنا any interference or to affect this expression. But in fact we can, and this means that both factors, the genetic and the environmental, play a role in craniofacial growth. في أشياء بيأثر عليها الجينيتكس أكتر، وفي أشياء بتتأثر أو بتحكم فيها الجينيتكس أكتر، يعني بضبطها أكتر، وفي أشياء لا ممكن عن جد تتأثر بالenvironment. يعني ال class 3 relationship is very well known إنها هاي mostly by genetics. usually بنشوفها بتتكرر في العائلات، يعني بنشوف طفل كلاس 3 حنسأل الأهل حنلاقي ممكن الأب ممكن العم ممكن الجد بنلاقي هذا الإشي بتكرر لكلاس 3. So we know it is controlled a lot by genetics. There are certain genes that make a patient class 3. Another thing is the prevalence of the class 3 in certain ethnic races. يعني بنشوف إنه في class 3 مثلا بالفار east كتير أكتر من الميدل east, and this also tells us that it runs in genes. So what you need to know is that, as we said, genetic and environmental influences both affect growth. The environmental influence can either support normal growth or hinder it. Like if the patient has good nutrition, then we can expect good genetic expression and total craniofacial growth. But if there was lack of nutrition, then we can expect problems to happen in craniofacial growth, reduced dimensions, delayed development, all of that. We will talk more about this in the lecture about etiology of malocclusion. بس في عنا كمان زي ما حكينا ال functional matrix can affect growth. So habits that affect this functional matrix like thumb sucking, swallowing, breathing, all of these can affect the way these structures in the craniofacial skull can grow. So last but not least, with all these studies of growth and attempting to understand it, there has been a lot of tries to also predict growth. يعني هل أنا إذا إجاني patient على عمر ال7 سنين Can I predict really how his malocclusion is going to be, how his face is going to be at the age of 17, for instance? Or if I treated a girl who is 12 years old, can I predict how her growth pattern is gonna continue and whether the treatment result that I have attained will be stable when the patient turns 20, or would it change? And we as orthodontists have been looking at so many things. We have been looking at height and secondary sexual characteristics to try to determine how close that patient to their pubertal growth spurt. Have they reached it? Are they about to have it? Or it's already مثلا too late. خدوها وخلصوا هلا. It's too late for us to intervene in terms of growth modification. There has also been attempts to study the hand wrist radiographs and use them as indications of the onset of puberty, but with very poor correlation. اللي أعطانا more accuracy كان maturation of the vertebrae or the cervical vertebrae per se on the lateral cephalograms. We can discuss this later in the growth modification lecture. But at the present time, what you need to understand is that it is really difficult to try to predict both the amount, the direction, and even the timing of growth of the skeleton with any degree of precision or accuracy. بس بشكل عام we can in general assume that a certain growth pattern will carry on as is إذا احنا ما تدخلنا and إذا احنا شايفين إنه هذا الباترن أصلا موجود في العيلة ف we can assume إنه هو رح يصير more severe أو رح نتأكد إنه هو رح يكون موجود later on when the patient grows. So by this we conclude part 3 of craniofacial growth. I hope this lecture was understandable for you. Maybe it was a bit long, maybe it had lots of new information, but at the end of the day, it's all about understanding. You just need to understand how we divide the craniofacial complex and each of these structures, how does it form and how does it grow, and the growth of it, how does it actually affect the patient clinically, and how does it affect the malocclusion and the appearance of the face, and what are the theories behind growth and what actually affects the growth of each of these structures. If you have any questions, please don't hesitate to reach out, and best of luck.